Welcome back to the Deep Dive, where we take your most complex sources, filter out the noise, and distill the knowledge that truly matters.
Today, we're embarking on a journey into longevity.
hmm
Specifically, what happens to patients years after they've successfully navigated a major vascular procedure?
And you, our listener, shared a really fantastic source with us. It's a highly detailed, systematic review and meta-analysis focusing on long-term mortality following a carotid endarterectomy.
We call it CEA for short.
Right, CUA. Okay, so let's frame this for everyone. When people hear about a blockage in the carotid artery, that's the main highway delivering blood to your brain, they immediately think stroke. And, rightfully so.
Absolutely. And CEA is this proven surgical technique where surgeons literally go in and, well, they physically scrape out that plaque, that atherosclerotic stenosis.
Just clean out the pipe, basically.
Exactly. To clear that blockage and dramatically reduce the risk of a future stroke, it's incredibly effective at that one thing.
At treating that local, imminent threat.
Yes. And when a CEA is successful, and most are, these patients are expected to survive for many, many years. So the crucial question this research asks is, okay, once we've successfully dealt with the stroke risk, what actually becomes the #1 long-term killer?
And this research, it's very recent, spearheaded by Daryll and Janice Tsui, just published in 2025.
It is, and it's essential because, knowing the long-term fatality profile, that dictates everything. It dictates how we should approach lifelong drug management for these patients.
I see. So if the biggest threat is still stroke, you treat them one way.
Right.
But if it's something else entirely, the clinical playbook, it needs a complete rewrite.
It does. And this review, it covers 60 years of data, studies from 1965 all the way to 2025. It gives us an answer that I think should fundamentally change clinical priorities.
Okay, so what's the high-level summary?
The big takeaway is this. After the initial recovery period, and we're talking about deaths that happen after the first 30 days post-surgery.
After you're out of the woods from the operation itself.
Precisely. Almost half of all deaths are not related to stroke.
Almost half. Wow. That is the big reveal we're going to spend the next several minutes dissecting then. If stroke prevention is the primary measure of the surgery's success, what on earth replaces it as the dominant threat?
Well, the sources identify 3 dominant, competing causes of late post-CEA death.
Yeah.
And it's their proportional distribution that really tells the story.
Okay.
The shocking reality is that the #1 cause, accounting for nearly half of all late mortality, is non-stroke cardiovascular causes.
A heart attack.
Heart attack, yeah. Or generalized systemic peripheral vascular disease, your whole vascular system, basically.
That immediately points to a deep underlying systemic failure, doesn't it? The surgery fixed the neck, but the body itself is still riddled with disease.
That is the core insight. It really is. Then the #2 cause is cancer.
Cancer. That's unexpected.
It is, and what's really interesting is that this proportion isn't just significant, it's showing a dramatic, statistically significant increase in studies from the past few decades. So that's a crucial area of rising concern we have to talk about.
Okay, so cardiovascular is #1, cancer is #2. So where does stroke land, the thing everyone was worried about in the first place?
Stroke comes in third, a surprisingly low proportion, actually. And in a way, that confirms the long-term durability of the CEA, but it also highlights just how successfully we've pushed that one specific risk down, only to reveal this much deeper, broader cardiovascular threat lurking just beneath the surface.
So to really appreciate the weight of these findings, and why we should trust these proportions, we have to spend some time on the methodology, right? This is what separates this kind of meta-analysis from just, a simple literature review.
Absolutely. The rigor here is paramount. The study adhered strictly to the gold standard of medical reporting, the PRISMA guideline.
Preferred reporting items for systematic reviews and meta-analyses.
That's the one. And they pre-registered their entire protocol with Prospero, which is the international database for this stuff.
Why is registering beforehand so important?
It's all about transparency and preventing bias. It means they had to publicly state exactly what they were going to search for, how they were going to analyze it, and what outcomes they were measuring before they even saw the data.
So they couldn't move the goalposts.
They couldn't move the goalposts. They couldn't just, adjust their search criteria or their outcomes based on what they were finding. The entire process was rigorous and planned from the very start.
And their goal was incredibly focused. They were only looking for randomized controlled trials, RCTs.
The gold standard of evidence.
That specifically and clearly reported the cause of late post-CEA death. And you mentioned this term late earlier. That seems like a major methodological power move here, doesn't it?
It is, and it's a brilliant way to isolate the data. They drew a very strict boundary, deliberately excluding any death that occurred within 30 days of the surgical intervention.
30 days. Why that specific number?
Well, because deaths happening in that immediate postoperative window, the perioperative period, they're often attributable directly to acute factors. Things like surgical site complications, issues with anesthesia, acute infections, or even heart attacks triggered by the sheer physical stress of the surgery itself.
Okay, so those deaths are about the risk of the operation.
Exactly. So by excluding those first 30 days, they're effectively saying, we're not measuring the risk of the operation, we're measuring the long-term risk of the patient's underlying chronic disease.
It's like clearing out the smoke after a fire. You're not counting the immediate burns, you're studying the long-term structural impact of the underlying problem.
That's a great analogy. The underlying problem here is systemic atherosclerosis, and this method lets them study its impact on the patient's longevity, isolated from the noise of the surgery itself. This choice ensures the resulting proportions are an accurate reflection of the patient's long-term disease trajectory.
Now, despite this massive initial dragnet, I think you said they searched the major databases and initially found something like 3,838 publications.
A huge number, spanning 60 years.
Only 27 studies actually provided the exact granular information they required, the specific causes of death after 30 days.
That is a staggering reduction, isn't it? And it tells you something really important about the focus of most clinical trials.
What's that?
Well, most RCTs are focused on the primary outcome. For CEA, that's usually preventing stroke in the short term, or maybe comparing two surgical techniques. Very few, historically, have had the resources, or even the mandate, to meticulously track and classify the specific cause of death over the long haul, years after the intervention.
So the fact they managed to find and pool data from 27 such trials is actually pretty impressive.
It is, given the historical scarcity of that kind of long-term follow-up data.
Okay, let's talk about the analysis approach. They didn't just average the numbers, they pooled the data using something called a proportional meta-analysis with a random effects model. Why is using a proportional meta-analysis specifically necessary here? Why not just tally up all the deaths and causes?
That's a great question. The key is that they needed to compare the relative importance of different causes of death across studies that were really disparate. I mean, imagine one study tracked 100 deaths and another one tracked 500.
Okay.
A proportional meta-analysis looks at the percentage contribution of, say, stroke versus heart disease within each study.
Yep.
And then it pools those proportions, weighting them by the study's size and its precision. It standardizes the comparison.
And the random effects model part, what does that do?
Right, so that's used because these 27 studies, they weren't identical, not by a long shot. They spanned decades, they had different inclusion criteria, different geographic locations, and certainly different standards of medical care at the time they were conducted.
So lots of variability.
Tons of variability. The random effects model is a statistical tool that's robust enough to account for that inherent variability between the studies. It gives us a more honest and, frankly, more generalizable result than a fixed effects model, which would assume all the studies were basically measuring the exact same thing.
Now, a crucial detail you pointed out earlier, the denominator. They didn't just calculate, say, the proportion of stroke deaths out of the total known causes of death. They used the number of all deaths post-CEA.
This is a subtle but absolutely critical correction. You see, sometimes in the original studies, a death might have been reported, but the specific cause was unclassified or listed as unknown.
So if you only use the known causes as your denominator,
you artificially inflate the proportions of those known causes. You make them seem more significant than they really are. By using all deaths post-CEA as the denominator, they ensure the final percentages, that 47% for cardiovascular, 6% for stroke, 17% for cancer, they accurately reflect the total mortality burden this population faces, even if a few causes went unclassified in the original trials. It's just better science.
They also used linear regression analysis to probe a bit deeper, right? Specifically to see if certain factors influence these proportions.
Yes, three main things. The year the study was published, the symptomatic status of the patient going in, and whether the patient had known coronary artery disease or CAD before the surgery.
And we should probably mention the duration of follow-up. The mean follow-up across all these studies was around 4 years. I think it was 48.9 months.
That's right. But the range was huge, from just 4 months all the way up to 120 months, so 10 years. And a listener might reasonably ask, does a study that follows patients for a decade have a different proportional breakdown of death causes than one that only follows them for 4 years?
It's a fair question. You'd think more time means more opportunity for different things to go wrong.
You would.
Yeah.
And that is precisely what the linear regression was designed to test regarding that follow-up duration.
And what did it find?
It found that the length of follow-up did not significantly influence the proportion of deaths for any of the three main causes.
Really?
Really? When we look at the stats for cardiovascular deaths, for instance, they found an R value of 0.12 with a p-value of 0.56.
Okay, let's translate that p-value of 0.56 into plain English for the listener. What does that mean?
It means there is absolutely no statistically significant correlation. There's a 56% probability that any link you see is just pure chance. So we can say with a lot of confidence that the length of the follow-up period doesn't skew this data. Whether a study followed patients for 4 years or 10, the underlying lethal proportional risks remain stable.
Which makes the final pooled numbers extremely reliable.
Exactly.
All right, let's turn to potential biases, because no meta-analysis is perfect. The authors were, from what I read, meticulous about identifying potential flaws in the underlying RCTs they use.
Yes, and they flagged several, starting with reporting bias as a high possibility in some of the studies.
And this is basically the danger of overlap.
It is. If the same group of patients, maybe from a big, high-volume vascular center, appears in multiple publications by similar authors over a short time frame, say 5 years, it's possible that the same patient outcomes are being counted more than once.
Which would artificially inflate or duplicate the numbers for specific centers?
Right. Then there's attrition bias.
Where the data suffers from missing outcomes, people just get lost to follow up.
Exactly. Attrition bias happens when a specific cause of death isn't reported for a significant chunk of the total deaths. And the danger is if those non-reported deaths disproportionately belong to a single category. For example, if all the patients who are lost to follow-up were actually the ones who died from a quick, undocumented heart attack at home,
then your proportional data becomes inherently skewed. You lose confidence in the overall accuracy.
you do. And the third one they flagged was performance bias, which sounds like it might be about the surgeon's skill, but here it refers to the study's primary purpose.
How so?
Well, a high-performance bias risk was noted when a publication's main goal was not specifically to determine the late causes of death. For instance, if a trial was designed to compare two different CEA techniques, say, using a patch, versus just closing the artery directly, and the reporting of long-term mortality was just a secondary footnote, that data collection might be less meticulous and therefore more biased than in a trial whose singular focus was tracking long-term mortality causes.
That makes sense. But what's really fascinating to me is what they didn't find. The authors specifically stated they found no paper suggesting selection bias.
This is a really important detail for any clinician listening. It means the patient selection for these trials wasn't specifically skewed by severe long-term comorbidities known to shorten life dramatically.
Things like end-stage kidney failure or patients who are already extremely elderly.
Exactly, or people who had simultaneous major heart surgery alongside their CEA. The patient populations in these trials, though high risk, appear to be a genuine representation of the standard CEA candidate pool.
So despite navigating decades of varying research quality, the statistical techniques they used were robust enough to pull the data and give us these clear, definitive proportions for the causes of death.
That's the takeaway. The methodology is sound.
All right, let's turn our attention now to the undisputed long-term threat, non-stroke cardiovascular mortality. The number is just staggering. Almost half of all late deaths are linked to this category.
Yeah, after pooling the data from 1,779 late post-CEA deaths, the meta-analysis found the precise proportion to be 47.1%.
47.1.
And the confidence interval is pretty tight, between 42.2% and 52.0%. This includes, as you said, heart disease, myocardial infarction, heart failure, and also severe peripheral vascular disease that leads to lethal complications.
47%. That means if you take two patients who successfully walk out of the hospital 30 days after their CEA, statistically one of them will eventually die from a heart-related or systemic vascular issue, not the stroke they were so worried about.
This high proportion is the most critical insight of the entire study, and it brings us right back to the fundamental nature of the disease itself. You mentioned it earlier, the CEA surgery treats a local manifestation of a systemic disease. This 47% proves that point with brutal clarity.
Let's delve a bit deeper into what we mean by systemic disease for the listener. The surgery fits the artery in the neck, but what else does this widespread atherosclerosis look like in these patients?
Well, atherosclerosis is a panarterial disease. It's everywhere. The plaque they find in the carotid artery is, almost without exception, also present in the coronary arteries that supply the heart muscle.
Right.
It's in the renal arteries that supply the kidneys, and it's in the peripheral arteries supplying the legs. A patient who qualifies for a CEA, meaning they have severe carotid disease, is, by definition, carrying a massive burden of systemic vascular disease.
So the immediate threat of a stroke from that one spot is gone, but the chronic threat of a system-wide shutdown remains incredibly high.
Exactly. They survive the acute carotid crisis, but they remain critically susceptible to what we call major adverse cardiovascular events, or MAE. And those are often fatal heart attacks. The fact that the proportion is nearly 50% just underscores that the cardiac system, not the neurological system, is the ultimate point of failure for this specific patient population over the long term.
But, despite this incredibly high proportion, the data gives us a powerful sign of success in the broader medical management world. The linear regression analysis showed a statistically significant reduction in the proportion of these non-stroke cardiovascular deaths in more recent publications.
This is a huge win for modern medicine. The correlation was highly significant, an R value of 0.61, and the p-value was less than 0.001.
And a p-value that low means?
It means we can be extremely confident this correlation is real and not just some random fluke. As the studies get more recent, the proportion of deaths attributed to heart disease drops relative to the other causes.
What's driving that proportional reduction? Is the atherosclerosis itself getting less severe, or are we just getting that much better at treating it?
The consensus among the authors and other experts is that this reflects a profound improvement in our overall medical treatment. We're not necessarily making the underlying plaque disappear, but we have dramatically improved our ability to manage the consequences. I mean, just think about the last 30 years. The widespread adoption of aggressive statin therapy for high cholesterol, far better control of hypertension with all these new classes of drugs, and much more sophisticated management of diabetes. All of those things play a huge role.
So we've gotten better at slowing the progression of the systemic disease. The whole clock is just running slower, which is allowing these patients to avoid that early vascular death that used to claim them.
Precisely. We bought them time with the CEA, and now we're maximizing that time by dramatically reducing the incidence of early MCE through better medical intervention. This reduction in that 47% figure is hard evidence that the lifelong medication approach, the non-surgical side of treatment, is really working to delay death from the primary underlying pathology.
But the challenge remains. Even with all these incredible advances, non-stroke CV causes still account for nearly half of all fatalities.
It does. It indicates that while we're doing much better, there's still enormous room for therapeutic improvement in the lifelong systemic management of these patients.
Okay, now, let's pivot to what the study calls the success story. This is where we confirm the enduring value of the CEA procedure itself.
Yes. When they analyzed 1,904 late post-CEA deaths specifically for stroke, the data is just striking.
A tiny fraction of these patients died from stroke-related causes.
The finding was that only 6.3% died from stroke. And again, the confidence interval is quite tight, from 4.5% to 8.4%.
Yeah.
This is the critical finding that confirms the long-term efficacy of the surgery.
6%. That number is just exceptionally low for a population who, by definition, had such severe cerebrovascular disease that they needed an invasive surgery to prevent a catastrophic stroke in the first place. How does that compare to general population statistics for stroke outcomes?
It's a massive difference. The source material references other epidemiological studies showing that in the general population of people who survive a non-fatal stroke, the long-term proportion of deaths from a subsequent stroke is often cited somewhere between 32% and 37%.
32%.
Or higher. Our CEA patients, who are inherently at a much higher risk because of their severe systemic atherosclerosis, are dying from stroke at a rate that's 6 times lower than the general previously stroked population.
So the procedure is fundamentally altering their trajectory. It's not just a patch. It's providing real long-term protection years after the surgeon has closed the incision.
That's the key takeaway. The CEA is not a temporary fix. It offers durable protection that holds up against the long-term progression of the disease. And we see this success reflected even further when we look at the trend analysis over time.
Right. We saw that non-stroke CV deaths dropped significantly over the decades, reflecting improved drug therapy. So you'd expect stroke deaths to follow the same trend, wouldn't you?
You would expect that, but no. And this is the fascinating part. The linear regression analysis demonstrated that the proportion of stroke-related deaths has remained remarkably stable over the entire 60-year time period of the studies.
So while the 47% CV mortality was proportionally dropping as medical therapy got better, the 6% stroke mortality didn't change at all. It just stayed flat.
Exactly. The correlation was negligible. The R value was 0.12 with a p-value less than 0.55. So statistically insignificant. And this stability is really counterintuitive if you're only thinking about medical progress.
How so?
Well, if improved general medical treatments, like better blood pressure control, which is absolutely crucial for stroke prevention, were the main driver of reduced stroke deaths, we would expect that 6% figure to also drop proportionally, right alongside the CV death rate.
But it didn't. So what does that stability reinforce about the specific benefit of the surgery itself?
It powerfully reinforces the intrinsic, enduring benefit of the physical surgical intervention. The mechanical removal of the plaque, that local fix, is the dominant factor keeping that stroke mortality risk stable and low, regardless of the significant improvements we've made in systemic drug therapy over the years.
So it confirms that the procedure achieves a level of local protection that generalized medical management alone just can't replicate in this high-risk population.
Yes, it's the final proof that CEA is not just life-saving in the short term, but it's life-defining in the long term, at least when it comes to neurological outcomes.
Okay, let's explore this other phenomenon, which you called a double-edged reflection of medical success, the reciprocal rise in cancer-related mortality.
Right. The analysis showed that cancer is a significant killer for these patients. It accounts for 17.5% of late deaths.
17.5%. That's based on about 1,400 deaths with a confidence interval between roughly 14% and 22%, so almost 1 in 5 fatalities.
And just as crucially, the linear regression analysis demonstrated a highly significant upward trend, a strong positive correlation. R equals 0.59, and the p-value was highly significant at less than 0.007.
So in plain English, as time goes on, a higher and higher percentage of patients who survive a CEA are dying from cancer.
That's exactly right.
Now, we have to be extremely clear for the listener here. We're absolutely not suggesting that the CEA surgery itself causes cancer.
No, not at all. There is zero evidence for that.
So if the surgery isn't the cause, what is driving this clear upward trend?
The authors propose that this is a classic and really powerful example of reciprocal change, or, to use the more formal public health term, mortality displacement.
Mortality displacement. Can you explain that in this context?
Yeah, think of it like a bottleneck in a pipeline. Historically, the primary, most immediate bottleneck for this patient population was a major adverse cardiovascular event, a heart attack, or some kind of systemic vascular failure.
Okay, the 47% category.
The 47% category. These events are generally what we call MC dependent. By improving medical therapies, the statins, the blood pressure meds, the diabetes control, we are effectively widening that cardiovascular bottleneck.
And as we successfully push down the proportion of those CV deaths, we're extending the lifespan of these individuals. They're living longer.
Correct. We are extending their lifespan beyond that vascular cliff they used to fall off of. And as they live longer, they naturally encounter competing MCE-independent risks. And the dominant one for any aging population is, of course, cancer.
So cancer deaths are filling the proportional space that cardiovascular deaths used to occupy.
That's the displacement. The successful treatment of one disease pathology, atherosclerosis, simply reveals the underlying risks of an aging demographic.
It's a consequence of success.
It is purely. We are pushing their survival into the time frame where cancer is statistically more likely to manifest and become fatal. And this isn't a new pattern in public health. We've seen it before. For example, when childhood infectious diseases were largely eradicated, other things like congenital conditions and early life risks became proportionally more visible.
So here we're seeing the inherent aging process become the dominant risk, but only once the severe early cardiovascular threat has been mitigated.
Precisely. It means that while we might eventually get that CV death rate down from 47% to, say, 30%, we should fully expect the cancer death rate to continue climbing proportionally to fill that void.
That's the trade-off. It's a sign we're doing a better job managing the vascular system, but it also flags a crucial future focus area. If we continue to optimize CV care, then cancer screening and management will inevitably become the next frontier for improving post-CEA patient longevity.
It has to.
All right, this next section offers some of the most powerful and, I have to say, counterintuitive clinical guidance for physicians because it actively disproves assumptions we might naturally make about a patient's long-term risk profile. The authors checked if a patient's status before surgery influenced what eventually killed them later on.
And the findings were remarkably consistent across the board. No, it did not. Let's start with the indication for the surgery itself. Whether the patient was symptomatic, meaning they had already suffered a TIA, a mini stroke, or a minor stroke, or asymptomatic, where the plaque was just found incidentally, but they hadn't experienced any prior symptoms.
Intuitively, you'd think a symptomatic patient has already demonstrated that their plaque is unstable and actively dangerous, suggesting a fundamentally sicker, more active disease. You'd assume they would be more likely to die from stroke or other CV causes later.
That assumption proved false, at least when it comes to the cause of late death. The proportion of deaths from non-stroke cardiovascular causes, from stroke or from cancer, was not influenced by whether the CEA was done for symptomatic or asymptomatic disease.
Wow.
For non-stroke cardiovascular deaths, the correlation was incredibly weak. R was 0.17 with a p-value of 0.43, basically no link whatsoever.
So their long-term fatal risk profile is defined not by their prior symptoms, but by the systemic nature of the disease that required the surgery in the first place. Once that one artery is fixed, the history of symptoms becomes less relevant to predicting the cause of long-term death.
That's it, exactly. The fact that the symptomatic status just washes out as an influencing factor over the long term confirms the power of the surgical intervention, and it reemphasizes that regardless of previous localized events, the entire patient population is unified by a single, severe systemic atherosclerotic pathology.
Okay, the second factor they looked at is perhaps even more counterintuitive. Known pre-CEA coronary artery disease status. I mean, if a patient is specifically documented to have CAD before the surgery, if they have a history of a heart attack or documented blockages in their heart, surely they're overwhelmingly more likely to die from non-stroke CV causes later on.
Again, the data strongly says no. The proportion of deaths from non-stroke CV, stroke, or cancer was not influenced by the proportion of patients in the studies who had known preoperative CAD.
That's amazing.
It is. Looking at the non-stroke CV mortality correlation, it was weak again. R was 0.33, P was 0.17, no significant link.
Wait, that is a profound clinical finding. If knowing a patient already has heart disease doesn't make them proportionally more likely to die from heart disease, what does that tell us about this patient cohort as a whole?
This is where the authors offer a really powerful piece of interpretation, connecting the dots on the systemic nature of the disease. They suggest that this lack of influence from known CAD reflects a high proportion of what they term occult CAD.
Occult CAD. So that's coronary disease that was clinically significant, but it just wasn't identified or documented or maybe even investigated before the operation.
Exactly. I mean, think about it. When a patient presents with severe carotid stenosis, it is highly, highly likely that they have significant blockages elsewhere. If the preoperative workup for the CEA patient didn't include extensive cardiac imaging or stress tests, or if the patient didn't report prior symptoms, that CAD status might remain unknown or occult.
But regardless of what's written on their chart, their body is in the same state.
The clinical reality is that the patient population undergoing CEA is so intrinsically and uniformly atherosclerotic that nearly all of them have severe systemic heart disease anyway, whether it's been documented or not. Therefore, adding known CAD to the mix doesn't actually change the ultimate proportional cause of death. It was going to be cardiovascular death regardless.
This has major implications for current clinical practice and screening, doesn't it? It suggests that treating the patient as a confirmed high-risk cardiac patient, regardless of what the preoperative workup shows about their heart, should just be the standard of care for every single person receiving a CEA.
It absolutely does. The data argues strongly against assuming a patient without documented CAD is somehow safer or requires less aggressive lifelong cardiovascular management. The systemic nature of their disease is the ultimate driver, rendering both their symptomatic status and their documented CAD status irrelevant to the long-term cause of death. The focus must be universal, aggressive MC reduction for all post-CEA patients, period.
So this systematic review is really less about looking backward and more about charting the course forward. If 47% of late deaths are non-stroke cardiovascular, then the clinical focus of lifelong care has to shift away from just stroke prevention as the primary goal.
The core recommendation is unambiguous. Future outcome improvements for these patients depend overwhelmingly on focusing on general cardiovascular treatments aimed at reducing overall MAE, not just maintaining the status quo of focusing so heavily on stroke-specific treatments.
And crucially, this new priority holds true universally. It doesn't matter if the CEA was done for symptomatic or asymptomatic reasons, or if they had documented CAD beforehand.
Right. Optimal lifelong medical therapy for this population must be comprehensive and aggressive. We have to treat them as if they are already severe cardiac patients, because they are.
And the authors emphasize 4 key pillars of this optimal MEC-reducing therapy that have to be managed for life.
Yes. First, antithrombotic therapy. Second, rigorous hypertension control. Third, aggressive hyperlipidemia or high cholesterol management. And fourth, detailed diabetes management.
As we discussed earlier, the advances in those latter 3 areas, controlling BP, cholesterol, and blood sugar, that likely accounts for the proportional reduction in CV death we saw in the earlier studies. But the authors identify a significant unaddressed gap in that first area: antithrombotic regimes.
They do. While the drug effectiveness for hypertension and hyperlipidemia has totally revolutionized care, the antithrombotic approach post-CEA has seen surprisingly little fundamental change. The protocol has traditionally focused on standard antiplatelet drugs, like aspirin or clopidogrel. And that's a regimen that is now being seriously challenged by newer, more comprehensive evidence.
This brings us to a major point of current clinical friction and a key takeaway from the source material: this implementation gap surrounding a study called the COMPASS trial.
Yes, the COMPASS trial, which stands for Cardiovascular Outcomes for People Using Anticoagulation Strategies, was a landmark study in cardiology. It looked at patients with stable cardiovascular disease and tested whether a combined approach, including a new class of drugs, could dramatically reduce MACE.
Tell us about the drug regimen they studied in that trial.
The trial utilized a DOAC, a direct oral anticoagulant drug, specifically a low dose of rivaroxaban, which was often used in combination with or without aspirin.
And the results?
The results were powerful. This combined regimen demonstrated a significant reduction in overall MACE. It reduced the risk of stroke, cardiovascular death, and heart attack in these stable CV patients when compared to just taking aspirin alone.
So if post-CEA patients are the quintessential example of high-risk, stable systemic cardiovascular disease, they should be the ideal population for this advanced antithrombotic strategy, shouldn't they?
Logically, yes. That 47% non-stroke CV death rate is screaming for a more aggressive MP reduction strategy. Yet, the authors point out there's been little traction in adopting this combined DOAC-based approach into standard care protocols after a CEA. This is a critical implementation lag.
Why the inertia? If the data from COMPASS is so strong, why aren't vascular surgeons and cardiologists universally updating their protocols for these specific patients?
Well, there are a few factors. First, there's just institutional inertia and what we call guideline lag. Clinical guidelines are slow to change, and the COMPASS trial's primary focus wasn't specifically on post-CEA patients, even though the patient profile aligns perfectly.
And the second reason?
Secondly, there's often a heightened perception of bleeding risk. Introducing an anticoagulant, even at a low dose alongside an antiplatelet drug, does carry an increased risk of bleeding. And surgeons and their patients are, naturally cautious about that, especially right after a major arterial surgery.
But the COMPASS trial data demonstrated that for the stable CV population it studied, the MACE reduction benefits generally outweighed the increased risk of non-fatal major bleeding events.
It did. And the source material highlights that other research shows patient acceptance and adherence to the COMPASS trial drug recommendations are generally quite good. So the challenge isn't compliance from the patient. The challenge is the leap of faith required by the physician to transition away from decades of standard antiplatelet therapy to this newer combined approach.
So, the fundamental gap is this. We have overwhelming evidence that these patients die of heart disease, the 47% number. We have strong clinical trial data from COMPASS showing how to reduce that specific risk in this exact population profile. But we are failing at implementation.
That's the essence of the challenge. If the medical community truly wants to drive that 47% non-stroke CV mortality figure lower, then aggressive optimization of antithrombotic therapy using the latest evidence, particularly the COMPASS data, is the next necessary and logical step in refining post-CEA care. The future of long-term survival for these patients hinges less on a new surgical technique and more on getting their lifelong drug regimens absolutely right.
We've covered a vast amount of detail in this deep dive into long-term CEA outcomes. Using Baker and Tsui's masterful meta-analysis, let's just briefly bring the key insights back into sharp focus for you, the listener.
The primary message is one of definitive risk assessment. The long-term durability and success of the CEA procedure itself is confirmed. That exceptionally low long-term stroke mortality rate, only 6% of late deaths, proves the surgical fix holds up.
But the real, enduring, long-term danger for this high-risk population is the systemic nature of their disease atherosclerosis. That results in non-stroke cardiovascular death, claiming almost half, 47% of all late fatalities. And that's regardless of whether they were symptomatic or had documented heart disease before the procedure.
And this knowledge, it really necessitates an immediate and universal shift in clinical focus. Future care optimization has to pivot aggressively toward comprehensive MEs-reducing drug therapy. That means ensuring lifelong compliance and, critically, eliminating that implementation gap in antithrombotic care by adopting advanced drug protocols like the low-dose combination regimen validated by the COMPASS trial.
And finally, the provocative thought this review leaves us with, one that could define the future of long-term postoperative care. If these aggressive medical therapies continue the trend of reducing that dominant 47% cardiovascular death rate, the proportion of cancer-related deaths, which is already at 17.5% and significantly rising through that mortality displacement we talked about, will inevitably continue to grow.
And that fundamentally shifts the key performance indicator for vascular care. As vascular specialists become more effective cardiologists and endocrinologists for their CEA patients, should the management protocols for postoperative care begin to formally incorporate mandatory aggressive cancer screening and preventative oncology measures? Does the responsibility of a successful CEA now extend beyond the vessel to the patient's overall future malignancy risk?
That's a huge question.
It is. And that may well be the defining challenge for improving survival rates for these patients over the next decade.